So thank you so much, everyone, for joining in. Today we have Dr. Idalys here with us from GluCare. This is the inaugural Eye on the Heart webinar started by us here at Mediwhale. Essentially, the reason we wanted to start this out was to help everyone understand how the retinal biomarkers can be used in the real world. So Dr. Idalys will be talking about how to explore the real-world clinical application of retinal imaging for the cardiovascular risk stratification. So before she starts, I'll just do a quick introduction for her. So Dr. Idalys, she graduated with honors from the University of Medical Sciences in Havana, Cuba. Then she completed a fellowship in internal medicine and has been working as a specialist cardiologist since 2018. She is an active member of the American College of Cardiology, the European Society of Cardiology, the Emirates Cardiac Society as well. And recently, she also passed the fellowship exam of the College of Cardiology, and she also has the FACC because of that. She has been working with GluCare.Health. GluCare is a unique full-service hybrid digital therapeutic diabetes clinic in the GCC region since June of 2024. And she is extremely passionate, and you'll see through her talk how she is involved with the special interest groups, especially with the heart failure, cardiovascular diseases, and the athletes, women, all the vulnerable populations, and also advanced echocardiography with strain imaging analysis. So I'll stop here, and Dr. Idalys, please take the floor.
Well, thank you so much for the kind words, and especially for inviting a cardiology to talk about the eye. So let's jump right into it. This is the outline for today's talk. We will talk about the cardiometabolic crisis, what's the problem, why we need AI, why we need to manage and make a risk assessment smarter. What is GluCare.Health? What is the new model of care that we are just doing here in UAE? We will give some examples of our real-life implementation of the Retina CVD tool, and we will just finalize with some clinical cases snapshots. So the American Heart Association recently released the 2025 heart disease and stroke statistics. As you can see, the burden of cardiovascular diseases continues to rise, and this is driven mainly by the alarming growth of key risk factors such as hypertension, diabetes, obesity, particularly in younger populations. This is a sobering reality. Cardiovascular diseases remain the #1 cause of death in the whole world, and millions of people die every single year. But what should really get your attention is that 80% of all of these deaths, they are preventable. When we look closer how we are doing in our region, we will see that we are not doing any better. So in UAE, we have one of the highest age standardized death rates for cardiovascular diseases, and with more prevalent risk factors than many other developed countries in the world. So what's the current standard of care? So how and why we measure cardiovascular risk? Well, first of all, we want to guide decisions on lifestyle changes and medications like statins, aspirin, and others. The goal here is to prevent both first-time events and recurring cardiovascular events. That's why we have different risk calculators used in different parts of the world. But each of these calculators, they have several limitations. Despite advancements, these calculators still rely heavily on traditional risk factors. They are known by underestimating the risk on special populations like younger patients and females, and also for overestimating the risk in older adults. So one of the most widely known calculators that we use a lot in our practice is the pool cohort equation. It calculates the 10-year risk or ACVD risk and uses coronary calcium score from cardiac CT to better risk refine patients in the borderline intermediate risk. So calcium score is a strong predictor of atherosclerosis. We can measure plaque burden, and a higher scores indicate a greater risk of cardiovascular events. And most importantly, what I want to emphasize that all these calculators have been built on populational data. They have been validated on foreign cohorts, and that for me is a huge limitation. I'm a clinician practicing in a multicultural setting in UAE. What I truly need is a tool that helps me to assess the actual risk of the patient that is sitting in front of me in the clinic. So let's go over a real life example of a patient that is coming to a primary care physician for cardiovascular risk stratification. As you can see, this is a 53-year-old female patient that has not active complaint, but she has a strong family history of atherosclerosis. She has some thyroid problems. She's currently on lisinopril, levothyroxine. As you can see, she's overweight. She has well-controlled LDL cholesterol, but triglycerides are elevated. She has prediabetes. And as you can see, when we enter all this information in the pool cohort equation calculator, the patient is just low risk because of the calculators is not assessing accurately her risk. So therefore, no statin is recommended for these patients. The primary care physician just reassures the patients, prescribe over-the-counter fish oil, and then we fast forward like 3 months. Unfortunately, the patient has a cardiac event 3 months afterwards. So as you can see, this is an event that could have been prevented. This patient had several risk factors for ACVD that were not addressed. This patient would have clearly benefited from GLP therapy, statins, and other preventive measures. So this highlights the dilemma that we are facing today with the current approach to primary prevention. 50% of patients are completely unaware that they have coronary artery disease until they have an event. More than 75% of patients, they have no preventive therapy before the event. And 20% or more of these patients, they don't receive optimization by primary care physicians. So when we cardiologists, we often talk about cardiovascular risk assessment, primordial prevention, primary and secondary prevention. But the truth is atherosclerosis exists in a continuous. There's a continuous risk of the ACVD risk. And we need to get better at identifying patients with advanced subclinical atherosclerosis, those who still are symptomatic but may benefit from early intervention. As a cardiologist, I find a lot of satisfaction in catching these patients before they have an event, before they experience these adverse events. So the challenge is clear, but so is the opportunity to rethink our approach, to drive research, to innovate. We need to find new tools and biomarkers that allow us to accurately assess patients' risk and intervene earlier to improve outcomes. So as Albert Einstein famously said, like insanity is doing the same thing over and over and again and expecting different results. That's why we have moved away from understanding disease to try to understand health and healthy aging. So last fall, the American Heart Association introduced a new risk stratification tool called Prevent. It is the first time that we are doing and considering risk stratification in younger patients. And for the first time, we are acknowledging the interconnectedness of the cardiometabolic kidney syndrome framework. This is a comprehensive, forward-thinking approach to cardiovascular prevention. As you can see, calcium score and the identification of patients with subclinical atherosclerosis plays an important role in this new framework as well. But for those of us in the front lines, calcium score may not be always accessible. So what if the eyes could be the answer to this? When I first heard about oculomics and specifically AI-driven cardiovascular risk stratification using retina scans, I was all in. So this is an exciting new field that is transforming how we assess cardiovascular risk. As many of you know, Mediwhale is at the forefront of this revolution, and I came across this understanding paper in the Digital Lancet of Health and about this deep learning algorithm that was able to predict coronary calcium score from retinal photographs. So RETI-CVD is an evidence-based, credible, and validated across diverse population biomarker with multiple publications in several journals that talk to us about the robustness of the algorithm. It's non-invasive, it's cheaper, and sometimes for us in the primary care settings, it's more accessible than CT scans. So to sum up, RETI-CVD established the foundation for early detection of atherosclerotic retinopathy. After all, the eye is the only place in the body that we can have access directly to the arteries. So this is like very quickly that, developing this retinal biomarker require a huge data set. Thousands of patients underwent fundus examination of the eye and also cardiac CT scan on the same day to train and validate the model. But the most important thing here is that CVD demonstrate high accuracy in predicting future cardiovascular events comparable to CT scan calcium score. But most importantly here, when we are just talking about the performance of CVD and the pool cohort equation, we can see that when we compare, the performance is very similar. But we have seen what is more compelling is the CVD and the pool cohort equation. When they are used together, the predictive accuracy improves significantly, suggesting that CVD helps compensate for some of the limitations of the pool cohort equation. It can be used as a standalone and also together with the current risk calculators. So this is what the report looks like. Many of you are familiar with the report, some demographic of the patients, the retina CVD score, the prediction of the calcium score, and the risk of the patient. In the second page, we will get access to the personalization for age and gender, and we will have some useful information as well about how to keep your heart healthy and some general recommendations. In my experience, presenting this data in this format makes much easier for patients to understand their risk. And understanding is what drives better conversations and better decisions and also behavior change. It is very important to understand that sometimes when we are using these calculators, patients, they get lost. They don't understand the numbers. So when we are presenting the data in this way, we gather the attention of our patients, and we say, for example, this is what is expected to happen because this is a projection of the upcoming 10 years. If you don't take any actions, patients are willing to make some changes. So now I want to talk a little bit about GluCare and how we are redefining metabolic health. GluCare is a hybrid digital and in-person metabolic center. We are based in Dubai. We are focused on tackling chronic cardiometabolic diseases like diabetes, obesity, hypertension, and dyslipidemia. These conditions that that drive massive parts of the cardiovascular risk. What makes us different is that we have completely reimagined the mode of care of our patients. Instead of being reactive, we are being proactive. We use a continuous care model, combine real-time data, wearables, remote monitoring, and a team-based care to guide smarter and earlier interventions. We are a multidisciplinary team of physicians, dietitians, educators, behavioral coaches, and we have a powerful data science and engineering team behind the scenes. That's why integrating retina CVD into our workflows fits perfectly into our approach. It is accessible, scalable, and aligns with our vision of early detection and prevention. Now, let me walk you through how we have integrated retina CVD into our clinical protocols at GluCare. We have designed this structured approach to identify adults without baseline atherosclerosis, but who have significantly metabolic risk, including people or patients over 30 years old with hypertension, high cholesterol, prediabetes, diabetes, and metabolic syndrome, and especially patients with family history of cardiovascular diseases. So we have different cohorts of patients here at GluCare. We have prioritized screening of diabetic patients in our diabetic package. We have type 1, type 2 diabetes, pre-diabetic patients. And as you know, compared with non-diabetic diabetic patients, they build more plaque and they have atherosclerosis earlier. We have cardiology patients, especially those patients who have hypercholesterolemia or family history of premature cardiovascular disease. We have patients with very high levels of LDL cholesterol. So we screen those patients as well. In the non-diabetic patients, we focus especially in special populations. We have a women's health program. We focus on screening patients with PCOS, with perimenopause, and we know that this cohort of patients, they are known, but being underestimated by the other tools. So for us, it's very important. We have our zone program, which is our weight and loss medicated program. So here's mainly patients in the cardiometabolic syndrome stage 1 or 2, and we want to try to find out whether the patient will benefit from proactive interventions like GLP-1 therapy, statins, and so on. And of course, we have our longevity cohort of patients that we want to, these patients, to help them to age and just keep healthy better. So by adding the retina CVD into our baseline assessment, we have been able to detect subclinical atherosclerosis earlier. We are stratifying our patients more precisely, and we are engaging them with a visual tool that helps them better understand their personal risk. This has helped us to optimize GLP-1 therapy, intensifying lipids therapy, and adding lifestyle and behavioral support. For us, this is what the next generation of preventive cardiology looks like, which is data-driven, personalized, and actionable. So after the screening of the retina CVD for the low-risk patients, we will continue with routine care and lifestyle optimization. As per protocol, all the patients that are in the moderate and high-risk group, they will be referred to cardiology. And there, I will just run some other exams in the case that are necessary. Perhaps I will do vascular ultrasound for the detection of non-calcified plaques or subclinical atherosclerosis, like advanced lipid panels, testing of inflammation with high sensitivity CRP, lipoprotein A, and in some very high-risk patients, we will do confirmation with CT coronary angiogram. So this is like our real-world evidence and implementation. I'm very proud to show these numbers. These are 6 months of screening at GluCare, what it looks like. We have screened nearly 600 patients, and you can see 264 patients in the low-risk category, 236 in the moderate risk group, and 91 patients in the high-risk group. So we are trying to win here the battle against atherosclerosis. So what happens when these patients are low risk and say we are happy for that and then no plaque, no problem? Well, we want to tackle atherosclerosis and we want to prevent. And it's very important to make the distinction here that patients, they cannot have subclinical atherosclerosis at the moment, perhaps, but they have risk factors. And then we know that atherosclerosis is a disease that starts very early in life. So that's it. Regardless of the risk stratifications, all patients in our ecosystem, they will benefit from integrating monitoring, dietitian support, continued glucose monitoring, sleep coaching, and behavioral optimization. And then we want more people to benefit from this approach. That's why this month we launched a new ACVD screening package. And this was inspired by the Lancet Commission of Health article that was just released a few months back. And it was a call to action to rethink coronary artery disease, to move from ischemia to atheroma. We were waiting too long to treat our patients. So this comprehensive screen includes lipid panels, high sensitivity CRP, AV1C, consultation with our GPs and risk stratification, and of course, retina CVD. This is a big step for us towards accessible, affordable, and proactive cardiovascular prevention, powered by data, personalized for each patient. So finally, let's go over a few case examples and how we have integrated these. This was one of our first cases that we identified with the retina CVD tool, one of our first high-risk patients. The algorithm predicted a high calcium score for this patient, more than 300. And when we did confirmation and run some analysis, the patient in the CT, as you can see, had more than 300 of calcium, like more than 400 of calcium score, was scoring very high for age and gender. And the patient, we identified a vulnerable plaque in the LAD that didn't need treatment. But this patient, moving forward, so the patient that started treatment with GLP, semaglutide, you will see PCSK9 inhibitors, you will see the levels of LDL cholesterol, how well he's doing with the weight, and it's been only a few months after the screening. So we have a second high-risk patient where the retina CVD tool correlated very well with the calcium score. As you can see, the patient was scoring the high-risk category, and the CT coronary angiogram revealed a calcium score more than 200 and severe stenosis in the posterior lateral branch that require angioplasty. And the patient is doing very well. So this is a very interesting case. We have learned a lot with all the patients we have screened so far. And we have identified a cohort of patients that are scoring high risk. Most of them, they are in the 50s, and they have calcium score before with 0 calcium, and the retina biomarker is identifying these patients as high risk for atherosclerosis. When we look closely to these patients, most of them, they have never have been treated with cholesterol medications. And you can see I did vascular ultrasound for this patient that had 0 calcium, and you can see an eccentric non-calcified plaque in the carotid wall. So this is the patient that can be being like falsely reassured with 0 calcium score, and we are just refining the risk for these patients and just implementing like preventive therapy. So stay tuned, because we will publish a case series with all these data, and we will tell you a little bit more about that. So and this is just a showcase that what we are seeing with the retinal biomarker is just that atherosclerosis results from the accumulation of cholesterol in the vessel throughout the life course. We want to emphasize that, and sometimes in the clinic, I tell the patients that we are looking sometimes at the snapshot of the cholesterol when the patient is coming to us, but we need to look back. What about the cumulative burden of high cholesterol throughout the years? That is what damages the artery wall. In contrast, we have this patient in the 50s, doesn't have risk factors for atherosclerosis, a very healthy patient with very well-controlled LDL cholesterol, scoring very low for Asian gender. And you will see how his risk for ACVD is very, very low. So you can get to your 50 with healthy arteries, and I think we will help many patients to get there. So finally, this is one of the cases that I want to showcase that this is not replacement for very good clinical judgment. Retinal biomarker is another tool that we have in our armamentarium to help you to guide better decisions. But for example, specifically this female patient, she was cholesterol lowering therapy for years. But when we did the retina CVD, the patient was scoring in the moderate risk group. So the patient has very severe coronary artery disease. So at some point, the retinal biomarker was underestimating the risk of this patient. However, when we look at the personalized cardiovascular disease risk assessment, it was a patient that was scoring very high for Asian gender. So you need to be highly suspicious. Anything above the 70 percentile for me, it is like very important. So what is next for us? We want to present all of this data. We will be presenting ADA, Mediwhale team, GluCare team with Dr. Milena. We are presenting the American Society of Preventing Cardiology. Hopefully we will have like also something to present in the European Society of Cardiology. So stay tuned for our just presentation. So just to conclude, I just want to say that this technology holds significant promises in refining risk stratification for our patients, enabling earlier, more personalized interventions, and ultimately improving patient outcomes. Thank you so much for your attention, and remember that the eyes may truly be the window to our patient's heart.
Thank you. Thank you so much, Dr. Idalys. I think that was a wonderful talk showing the breadth of your experience that you have, and also the depth of understanding of why prevention is so important and why we need to move now away from the reactive approach that we have into the more proactive approach. So we have one question from the audience. So the question is from Dr. Deepthi, and she's asking, from your experience, which are the retinal biomarkers or retinal signs that you feel are associated with the ASCVD events or with the Farmingham score or with the high risk of ASCVD detection? I think we also went through some images together and saw some of those signs. So if you could just put some light on that.
Yes. I'm learning a little bit about the retina, how to look at the retina, and sometimes I just look at the fundus examination and try to predict also what is the risk score of my patients. I'm not an ophthalmology yet, but we were very puzzled with these cases that were scoring high risk. And then, with the help of Sahil, we look closely to the images of the retina, and we saw some signs, mainly AV nicking in some patients, some exudates. So all of this that we know from previous research before oculomics that were linked to subclinical cardiovascular disease and vascular deterioration. So this is mainly what we are finding on these patients, and sometimes also some signs that the patient have hypertensive retinopathy and hasn't been treated at all. We cannot forget that we have different phenotype of hypertension, which is a major risk factor for atherosclerosis as well, of course, beyond the LDL cholesterol, which is one of the most important. Some patients, they will have mass hypertension. Sometimes they come to the clinic and they are completely normal, the values of BP, but they can have blood pressure elevated at home. So these are mainly the signs that we have found in the retina examination into subclinical atherosclerosis.
Okay, thank you. Thank you, Dr. Idalys. Yeah, you're totally right. There are some signs in the eyes that reflect higher risk. So, as you mentioned, the arteriolar narrowing or the vessel or the CRVE, which is the central retinal vein dilation, or the vessel tortuosity, or the AV nicking signs, and also the undetected diabetic retinopathy findings like the microaneurysms and the hemorrhages, and even cotton wool spots and exudates at time. These are the things that have been found to be associated with higher risk of cardiovascular disease. So there's another question from the chat as well, and this question is about mentioning diagnosis in one of the slides. I will also kind of here and add on the part like how you described that the retinal imaging may sometimes reflect lower than expected cardiovascular risk, especially in people who are under treatment. So I think in that perspective, I would just like to know how important is it for the physician and their role? After all, again, RETI CVD is just another tool. The clinical diagnosis, I'm sure, definitely always will be the clinician's prerogative, and they will have to take into account all the other findings that the patient has, right, before they can actually use a tool to diagnose. Because again, these are tools which are there as clinical decision support tools. I would just like your opinion about that and how you think that this personalized approach to individual patient is required for any new technology that is coming in.
We have come to realize that the tool works better in patients naive, like in patients that haven't been treated at all. So when patients come to the clinic for the first time and we will initiate like any therapy, or we are thinking about initiating any therapy, is the perfect opportunity to do the screening. Because we have seen that patients that are undergoing any treatment, and I also learned from the ophthalmologist that the retina is very sensible and it changes. And that's the reason we are like running now the second phase, as I call it, of the rollout of the retina CVD. After we have screened the patients, most of the moderate and high risk patients that we have started treatment for them to lower their risk, and all the patients that have been losing weight, controlling the blood pressure, the LDL cholesterol. We want to repeat the exam and to see whether we find any changes, either in the score of the retina or in the personalized risk stratification. So it is very important to make this distinction. And also when we are just doing like calculations with the current calculators, when patients come for follow-up and we enter the values of the patient, of course, we will have lower values. So we expect the same for the retina CVD. So if a patient is already under like medication and preventive therapy, let's say like cholesterol lowering medication, blood pressure medications, perhaps RETI CVD may not be the best tool to reflect the real risk of the patient.
Definitely, I agree. So there is another question from the chat, and thank you so much for being so active on the chat. That means definitely the session was very interesting for you guys, and we like that the interaction is going on so well. So the question is, for example, if you find someone who is at high risk, do we always need to do a CT scan to diagnose, or just essentially start the patient for treatment? I think this again boils down to how you are integrating the tool in your practice, and I would just like to know what you think about that. Definitely,
Yeah,
for all, you don't need the CT scan, right?
No, actually, this is a very good question. And as per guidelines at the moment, we don't do CT scan for primary prevention, especially CT coronary angiogram. In the upcoming years, I'm sure that's going to change. There's a trial underway that's called Transform, where we are just doing these kind of things. We are trying to detect subclinical atherosclerosis in patients, especially in high-risk population. But you have to remember that I work in a metabolic clinic. Most of my patients, they are very high risk. And sometimes diabetic patients, they may not have typical symptoms of the disease. So I need to be highly suspicious. Some of these patients will tell me they are completely asymptomatic, and I need to stress them out first with exercise stress tests, equa stress, to get to know whether they are completely asymptomatic or not. The level of suspicion is very important. Of course, we don't do CT coronary angiogram for all the patients unless the patient has any symptoms. But I think the movement in cardiology is going to be in the coming 3 or 5 years that we will start doing more CT coronary angiogram. At the moment, we do more calcium score. Why? When patients are asymptomatic, it's very important to identify patients with elevated burden of subclinical atherosclerosis, which means most of these patients in the high risk category by retina CVD. So perhaps retina CVD can help us to choose better the patients that may need these costly imaging studies. So, because for us cardiologists, when we find a patient that is asymptomatic and has 300 or more of calcium score, it's a patient that his risk is very similar to a patient with established coronary artery disease. So there's no distinction. So that's the importance that even in the prevent and just the current framework of the cardiometabolic syndrome, we need to identify patients with subclinical atherosclerosis, because before calcium score and atherosclerosis was about initiating treatment with statins. Nowadays is more than that. We are very fortunate in preventing cardiology to have so many drugs like GLP-1 receptor agonists. Like we also have CGLT2 receptor agonists for patients with diabetes. We have aspirin, we have PCSK9 inhibitors, we have highly purified omega-3. All of these therapies, they lower adverse cardiovascular events.
Sure, definitely. I definitely agree with you, Dr. Idalys. And I think this also brings us to the concept that you also touched inside your slides about how lifetime risk and the cumulative burden of risk factors is more predictive of events than cross-sectional measurements. I think because I'm a glaucoma specialist, I'll draw a parallel from glaucoma. So where the IOP range, the intraocular pressure ranges from 12 to 21, and if you have someone who's coming in with 20 Hg every visit, it will still lead to optic nerve damage over the longitudinal time. And I think it's almost similar for cardiovascular disease prevention as well. So I think this question I will also link with something that is coming in from the chat. The question is, can the retina scan for CVD be used as primary healthcare centers? And then if there is a risk from that, the subject can be advised for further tests. So in a way, it is capturing that burden of risk in the population and then guiding towards more individualized and personalized care based upon catching these patients with high risk. Do you agree with that? What's your opinion about that?
Yeah. I think that the problem, I mean, the challenge is clear. We need to change these numbers. And of course, atherosclerosis is very prevalent. And as you see, this is the dilemma we face in primary prevention, that patients are having the event and they don't even know that they have clinical atherosclerosis. But for example, the case one now, that the patient I presented, that he knows already that he has a vulnerable plaque, is a patient that will never dismiss any symptoms coming from the heart. Any minimal chest discomfort, he knows already the red flags he needs to look after. So we need to educate our patients. We need to educate our patients to seek medical care like earlier as well. So in this point of view, Retis CVD help us to educate the patients, to showcase them that they have already some subclinical disease. They can never dismiss any symptoms coming from the chest. They need to control the LDL cholesterol to avoid plaque progression and so on.
Definitely. I think this has been a great session. We are already 4 minutes over our time. Thank you so much, Dr. Dallas, and thank you everyone who joined in. We'll definitely try to have more such webinars in the future as well. And with the amount of research that is going on and the effort that clinicians like Dr. Dallas are putting in, I'm sure Oculomics is ready for the big world. People will take us more seriously, and more ophthalmologists will be there at cardiovascular conferences, while cardiologists will be there with the ophthalmologists at our conferences. So thank you so much again, and it's been
My
great.
pleasure.
Thank you again. Yeah.